Utilizing this knowledge, we're going to discuss extracardiac manifestations of those channelopathies. Then we're going to sum it all up by coming back to our paper, our results, our clinical relevance of these results. So first off, long QT syndrome. What is it? Well, it's a group of inherited and acquired disorders. Basically results in abnormality in the repolarization and depolarization of the cardiac action potential, which is a result in prolongation of the QT interval. That prolongation basically increases your risk for entering the trademark arrhythmia of Torsades. And to a physician, this can present in many different ways as far as long QT syndrome goes. It can be syncope, seizures, or just sudden death as the first initial onset. Its prevalence is actually 1 in 2,000, which is more common than you might believe. It's also the leading cause of sudden death in children. So this is something you'll likely see in your career. To date, because of the severity of this disease, over the past 2 decades, a lot of work has went into determining the genotype and genetics that underlie these channels and the mutations that result in abnormalities. 13 have been described to date, but 90% of those with genetic or genotype positive long QT syndrome localized to these 3 genes specifically. Looking at those genes, we've started to evaluate, we know how it presents in the heart with the clinical severe presentation, but how does it present in other organs? Because we know these channels are in other places. Well, in 1957, Javel and Lang-Nielsen actually released a paper of a syndrome that's autosomal recessive in nature. It results in prolongation of the QT interval. It is accompanied by sensory neural hearing loss, which is actually secondary to the potassium channel functioning abnormally within the inner ear. Following this, we started to look for other extracardiac manifestations, and it's been shown that patients with long QT syndrome type 3, which is mediated by the sodium channel, present more commonly with abdominal pain, and patients with long QT syndrome type 2, mediated by a potassium channel, are more often to diagnose or disclose that there's a personal or family history of seizures. Johnson and et al. Reported this study, but one of the confounding variables is a ventricular arrhythmia can induce cerebral hypoxia, causing a seizure. However, the patient could also be having seizures, primarily from the channelopathy. So we can't state what the actual cause is of those seizures. So the hypothesis was formed that the same channel in the heart is also functioning abnormally in the brain, causing epilepsy. However, we can't prove that from this paper. Following this, we recently published a case report of a patient who had known long QT syndrome, who had never been symptomatic, diagnosed incidentally through a family line. And as you'll see here, in these 2 boxes, there's epileptiform activity present while the patient's in sinus rhythm. That, to us, made us think, well, this patient has epilepsy because it's unprovoked epileptiform activity. However, the heart is functioning normally. So it raised the question for our study today about what is the actual prevalence of long QT syndrome and concomitant EEG documented epilepsy. And once we know that, can we take a look at these patients, both the phenotype and the genotype, and have any clues into a potential shared pathogenesis between the 2? To perform this study, we released these methods, and these are actually updated from what's in your abstract, because with any genotype study, results are always coming back. So these are autographs. We performed a retrospective chart review of 610 total patients with diagnosed long QT syndrome. And those were seen at the Mayo Clinic's LQTC clinic between 2000 and 2013. And then we utilized 2 very important inclusion criteria for this study and to involve the study cohort. First, the patient had to describe seizures or seizure-like episodes. Now, seizures were described by 1, aura or phenomenon, knowing that something's going to come on. 2, during the seizure, there had to be automatisms or focal neurologic signs. And 3, following this, there was a postictal state. Very different than syncope, rapid onset, short off, no postictal confusion. After that, we subdivided this group into those patients who underwent neurologic evaluation and subsequent EEG. And only those patients with EEG documented epilepsy in the presence of sinus rhythm are the final cohort of our study. I'm going to walk you through what we see then with our results. Overall, there's 610 patients with long QT syndrome. Of those, 67 were ultimately receiving a neurologic evaluation. That represents 11% of the total. Of those 67 patients, 39 of them were evaluated by a neurologist and subsequently underwent an EEG evaluation. Looking at this 39 individuals specifically, the demographic data shows, is shown here at the right. Overall, slight female predominance, 25 out of over 14 males. The age of diagnosis was relatively skewed because we were all the way from infancy to adulthood, so 28 plus or minus 16 years. The QTC was slightly on the long side with 461 plus or minus 46 milliseconds. And the LQTS subtype was slightly predominant for long QT syndrome type 2. The results we were able to draw from this is that among the 39 patients who underwent a neurologic evaluation in EEG, 9 were found to have EEG documented epilepsy in the presence of sinus rhythm. There was a slight predominance for patients with long QT syndrome type 2, and the majority of the patients actually had partial epilepsy, as a total number of 6. Now these are hard to hear, so here's a graphic representation of what we're actually looking at. On the y-axis is total number of patients. Across the x-axis is LQTS subtype. Under each subtype, you'll notice the total number. That's in the entire LQTS cohort. So across that x-axis, that adds up to 610. The blue lines represent those patients with a seizure phenotype, so those patients that had seizure or seizure-like episodes. And the gold represents the patients with EEG documented epilepsy. Fisher Exact was utilized to review this sample, and we did find statistical significance with a p-value of 0.001, and you'll see that there's a predominance of LQT2 patients with this presentation. Looking at just those patients with EEG documented epilepsy, gender is relatively equal, 4 females to 5 males. The age of onset was pretty young, 12 or plus or minus 11 years for the diagnosis of long QT syndrome. Average QTC was on the longer side, 493 plus or minus 46 milliseconds. Age of first seizure is quite young at 11 plus or minus 9 years. And there's a slight LQT2 predominance, as we talked about. I'm going to overlay here the genotype and phenotype data. And in this chart, it's very hard to take away kind of a gestalt. But what we're looking at is multiple mutations were noted from frame shifts to dilatations. And on the protein, several different regions are involved, from the pore to the per-arc-sim domain to the C-terminal. So there's no one overriding theme that we saw. We did know that on EEG localization, 3 of them, all of which were long QT2, had temporal localization, and the MRI really didn't show any significant changes in the patients that had underwent that evaluation. So from this, we draw our conclusions. Overall, in our review of the large cohort of LQTS patients, 10% presented with seizure-like episodes. Just over half of these patients were referred for a neurologic evaluation, which revealed EEG-positive epilepsy in 9. The prevalence of LQTS and concomitant EEG-positive epilepsy in our cohort was 1.5%. And that likely is a slight underestimate because utilizing that EEG, it is not required by a neurologist for a diagnosis of epilepsy. And akin to our previous findings, looking solely at seizure-like symptoms, it does appear that EEG-positive epilepsy is more common in patients with long QT syndrome type 2. So what's the clinical relevance of this? Well, the overriding thing for the general pediatrician is that seizure-like symptoms are common in LQTS. It should not be dismissed early as being secondary to the cardiac cause. If suspicious, a neurologic evaluation is warranted. In our research perspective here is that LQT2-associated potassium channels are also found in the brain. But whether the mutation in the channel is really the pathogenic cause of the concomitant EEG-positive epilepsy still has yet to be determined, and that's our future goal. But we are seeing this overrepresentation in long QT2, which gives us some excitement into that channel specifically. I'd like to thank my research mentor, Dr. Ackerman, and our clinical supervisors, Dr. Bose and Dr. Casino. And thank you, and I'll open the floor for